Nasogastric intubation. Gather equipment: NG tube, non-sterile gloves, cup of water and straw, a towel, emesis and wash basin, lubricant, stethoscope, pen light or flashlight, tape or coverlet dressing, tongue depressor, safety pin and rubber band, irrigation set with piston syringe, suction machine with tubing, and a plastic connector. Perform hand hygiene. Verify client and explain procedure. Ask if client has ever had an NG tube or has a known latex allergy. Place client with head of bed up at 45 to 90 degree angle unless contraindicated. Tear 2 or 3 pieces of tape. 1 tiny piece of tape to mark the tube after measuring, a 2.5 to 3 inch piece with a 2-inch split down the center for anchoring the tube to the nose if coverlet dressing is not available. And a 2-inch piece to use to secure tubing to gown with a safety pin if desired. Apply non-sterile gloves. To determine nair to be used, instruct the client to close one nair and inhale through the nose, then repeat, obstructing the other nair. Question client about history of nasal fracture, surgery, or deviated septum. Inspect the nairs with a pen light. Starting at the tip of the tube with the holes, measure the tube from the tip of the nairs to the tip of the earlobe, plus the distance from the earlobe to the tip of the xiphoid process. Mark the distance with a tiny piece of tape. Do not wrap the tape around the tube. Place the towel across the client's chest. Lubricate 6 to 10 centimeters of the distal tube with a water-soluble lubricant. Place the distal end of the tube, the non-lubricated side, in the basin as needed to collect gastric contents. Gently insert the tube through the nair and posterior nasal pharynx, keeping the tube at the base of the nair. After passing through the narrow turbinate area, rotate the tube 180 degrees so the tip is pointed upward. This aids in preventing the NG tube from slipping into the trachea. If client is unable to cooperate or swallow, bend the client's head forward slightly to facilitate the tube entering the esophagus. While tube is advanced into the oropharynx, instruct the client to swallow repeatedly. If permitted water, have the client take sips while the tube is being passed. Advance the tube to the marked area. Remove the small piece of tape used to mark the tube while holding the tube in place. Secure the tube to the nose temporarily to prevent it from slipping out. If using the split tape, place the unsplit portion over the nose and wrap one of the split portions downward and around the tube. This helps to assure that the tube remains in place, yet will allow the nurse to easily undo the wrapped portion to advance the NG tube farther if necessary. Confirm placement according to agency policy. In the nursing skill lab, placement will be confirmed by introducing 30 mL of air via the piston syringe and listening over the epigastric area with the stethoscope. With syringe still attached, aspirate by pulling back on the plunger for gastric contents. If gastric contents are obtained, return the contents through the tube when appropriate. If the tube will be used for medication administration or feedings, Chest X-ray must be ordered to confirm the initial placement. If used for only gastric decompression, a chest X-ray is not needed. Connect the NG to suction tubing. Turn on suction to prescribed setting. Low intermittent suction is common. Finish securing the tube to the nose by wrapping the other split portion of the tape downward and around the tube in the opposite direction of the first piece. Secure the NG tube to the client gown by wrapping the third piece of tape around the tubing to form a tab and then securing the tab to the client's gown with a safety pin, preventing the tubing from dropping below the bed. A variation that we're showing you in this video is you may use a rubber band around the tube secured with a safety pin. Then wash your hands. And then document. Documentation would include
date, time, signature, credentials.
The procedure performed and purpose, the type and size of the tube, the nair used, verification of placement, the suction setting, assessment of output, and teaching learning response. Irrigation of an NG tube. Routine irrigation is generally done once a shift. Irrigating an NG tube more than once every 8 hours may not be necessary. Repositioning the client may facilitate improved NG function if the tube is not draining properly, which may eliminate the need to perform additional irrigations in some cases. If clogged, the NG tube may have to be removed and reinserted. Check with the surgeon in cases of oral, neck, nasal, or gastric surgery prior to inserting or irrigating an NG tube. Wash your hands. Verify correct client and explain procedure. Determine if suction machine is functioning properly. Apply non-sterile gloves. Turn suction off. Disconnect the NG tube from the suction tubing and confirm placement of the tube according to the agency policy. In the nursing skill lab, this is done by injecting 30 mL of air while listening over the gastric area and by aspirating gastric contents. Further, assess the pH of the aspirate per agency policy. Fill the piston syringe with 20 to 50 mL of water or normal saline. Instill the fluid. Reconnect NG tube to suction tubing. Resume suction. The solution should return freely. Remove your gloves, wash your hands, and then document. Documentation would include
date, time, signature, credentials.
Procedure performed, verification of placement, amount and type of solution used, suction setting, record the volume instilled on I&O, and teaching learning response. Removal of NG tube. Equipment: towel, non-sterile gloves, piston syringe, emesis or wash basin, and stethoscope. Wash your hands. Verify correct client and explain procedure. Turn off the suction apparatus. Confirm the presence of bowel sounds. Position in high Fowlers unless contraindicated. Apply non-sterile gloves. Draw 20 to 30 mL of air into piston syringe. Disconnect the NG tube from suction tubing and connect syringe. Clear the tube with air and leave the syringe attached. Unpin the tubing from client's gown. Place a towel across the client's chest and have an emesis basin or wash basin available. Remove the tape from the client's nose while holding the NG tube steady. Instruct the client to hold his breath, close his eyes, and remove the tube gently and quickly. Assist with or perform oral and nasal hygiene. Assess and measure the gastric contents in the receptacle and dispose of equipment per agency policy. Remove your gloves. Wash your hands and document. Documentation would include
Date, time, signature, credentials.
procedure performed, quality of bowel sounds, assessment of output, record the volume on I&O, and teaching learning response.